in the era of rampant use of the accessibility to thyroid function tests has increased, and as we know, a lot of the parents are very anxious about even slight weight gain, which is becoming a very common cause of ordering these tests. And we see thyroid function tests done by our general pediatric colleagues and many times referred for opinion. That's how we often see. And I hope there are delegates who are today, in addition to pediatrician and pediatric endocrinologist and other endocrine colleagues, if there are general pediatric people, this talk would be of definitely some use to them, but it will be definitely a revision for us. And I will be very happy to learn from Professor Raghupati sir and other seniors in the team on the thoughts which I'm going to share. So I will discuss this topic of subclinical hypothyroidism under the headings of going through the definition, which is age old now, and what is normal TSH of children. We are not talking congenital hypothyroidism now. We are only talking of children above the age of 3 years for all practical purpose in this discussion. And is there data from India, how much and how common, and why are we concerned, and the practical algorithmic approach to a child who comes with an elevated TSH. So as we all know, this is, as the name indicates, subclinical. This is a biochemical diagnosis where the thyroid stimulating hormone, for definition purpose, is defined as above the statistically defined upper limit of reference range. Every word in this statement can have a discussion for more than 5-10 minutes as to what is the reference range, what is the limit, which assay, etc., which we will mention as I go along. And with normal thyroid hormones, both usually T4 alone is done, and there we have already discussed the difference between free and total, and basically for clinical purposes it is T4. And clinically the baby should be otherwise normal with respect to thyroid. You should not have clinically obvious features of hypothyroidism. If this definition, there are many studies which have been done which reference ranges varying anywhere from the upper limit of 4.5 to even 6.5 based on the kit, etc. So whenever you see a report of subclinical hypothyroidism paper, etc., we need to know what the reference range they used, and based on which the prevalence will obviously vary. So if you see, we happen to write a detailed review on this as of 2014 with my colleague long time back, and that time we happened to, he was our pediatric colleague who was very interested to know. Every time they included this checkup in one of the corporate hospitals in Chennai in the general health check for the child. So every time any child with obesity, the TSH report will come, and everybody was starting on every dose. So we happened to review, and certain things we learned in a very hard way on that day. So I'll revise some basics before going into the practicalities. So, and that is, these are all the common etiologies of hypothyroidism that applies for subclinical also. What we are worried as a clinician is a condition like autoimmune thyroiditis, which is long term and which can have remissions and exacerbations. And that is why you see this diagnosis on both sides of this slide, which is in the irreversible cause also you have autoimmune thyroiditis. When I say it is reversible, it means because the autoimmune phenomena can go into remission, and many times the elevated TSH just normalizes in many people. You will be surprised to see the incidence in various studies that this could be to the tune of almost 2/3 of the babies, it just normalizes. And we need to know that one should not check the thyroid when a child is sick, as well as a good history of a viral illness in the recent past, either upper respiratory infection or urinary tract infection, etc., will definitely affect the thyroid. These are all because of non-thyroidal illnesses syndrome, where the thyroid actually is normal, but it responds to the illness in a different manner. And the TSH will usually get elevated when the child is recovering from an acute insult. Antithyroid drugs, etc., can be very well assessed by history. Most important, this will be very useful for pediatricians who may be listening to this talk. Any child with obesity, there are a lot of information on obesity per se elevating TSH rather than the other way around. A common misconception is hypothyroidism causes obesity. In fact, even in profuse or overt severe hypothyroidism, when a child comes with a puffy, coarse face and weight gain, more often it is the hygroscopic effect of the glycosaminoglycans and water retention, which will rapidly reverse to the previous normalcy with a few weeks of thyroxine, which you would have many times seen senior people here. So Just to tell you that obesity itself can elevate the TSH due to the interaction between the hypothalamo-thyroid axis and leptin. And a child with another endocrinopathy like cortisol deficiency, either due to pituitary or adrenal cause, in both senses, due to the suppressive effect of cortisol being lost, TSH may get elevated. Of course, I had to mention even in the article that we have to mention the laboratory is an issue in our place. We need to know what kit is used and what assay is done, whether they have changed it, whether there are some issues in the recent kit, etc. But that is beyond the purview of today's discussion. In this component, so this component needs to be remembered whenever we see a child with this problem. However, the right half of this slide is very easy to understand. Child, I'm sure our counterpart from US will be definitely speaking on thyroidectomy and thyroid nodule, etc. And with any child with this kind of history, everybody understands this is more likely to be a permanent kind of hypothyroidism which the child may have. So from here, just to share two slides we had published some time back. Every time a patient comes to us, this is studies done in adults, but this is relevant for children also. I have seen a couple of abstracts in conferences presented on children where whether the test should be done in fasting or anytime. And this question was answered, and it was very surprising that every study done in this respect, especially from US and others, the TSH definitely shows a diurnal variation and a significant decline postprandially. So any TSH done after 10:30 to 11 a.m. in the morning is always lower than the TSH done before that time. Then it came to us whether this is due to the food or this is due to the timing. So another paper we just published to show that it is not the food but the time which alters the TSH. So a practical point from this kind of discussion is, if at all we are examining a child or for that matter an adolescent who will be almost entering adulthood, kindly check TSH in the morning hours. The value can change to the tune of 0.6 to 1.2, 1.5 depending on the kit you use. So a child may hover between the upper limit of normal or elevation above the limits of normal based on these timings. So this also might play a role. To avoid this, if you want to convincingly diagnose subclinical forms of hypothyroidism with minor elevations in TSH, it's preferable to do a morning sample. But anyway, these obesity and other things, we anyway check metabolic profile. So fasting sugar may or may not be with insulin and lipid profile, etc. So a fasting sample may also be prudent, but fasting is not the only thing. It's the timing which is very important. So in this background, we need to understand that when we see papers on prevalence of subclinical hypothyroidism in children, very importantly, there are a couple of very good Indian papers, one by Professor Marwaha et al. Published almost a decade back. More than 3,000 children screened for TSH, T3 and T4. And in that paper, the subclinical hypothyroidism by that kit and upper limits of TSH, it was to the tune of 6.1%. It's a huge number. And overt hypothyroidism was fortunately very less. And very surprisingly, by the WHO definition of the prevalence of goiter in children, which is the upper limit is around 5%, it was seen to the tune of 15% in that case, and almost 3% of those children had TPU antibody positivity, more so in girls. This is one important paper we need to discuss whenever we discuss TSH and children. Another paper from Chandigarh by our colleague Dr. Samvid Das. Here also the goiter was pretty high to the tune of 15%. Subclinical hypothyroidism was somewhat lesser. In both these studies, and similar to one more paper which I'll quote, the iodine sufficiency, unfortunately, for various reasons, was not confirmed so that could be always a confounding factor in many of these papers, which also need to be kept in mind. In contrast to these Indian papers, a couple of insurance-based US papers report subclinical hypothyroidism to the tune of 2 to 3% in those kind of papers. Other things are all small series from, these are all population data and big numbers, so I quoted these papers. You can have many hospital-based data from other papers. In addition to these general screening of children, as clinicians, we understand that TSH is always, the hypothyroidism is associated or for a higher risk in children with type 1 diabetes, Down syndrome, or other autoimmune diseases like celiac disease, and patients on anti-epileptic drug therapy. So these are all high-risk children where you are bound to have some thyroid issue, and active screening is indicated. So the other patients whom I discussed in the other papers are all not belonging to this high risk category. And I have already discussed how obesity definitely affects TSH. So the presentation is very vague in contrast to the classic overt severe hypothyroidism in children, where every pediatric conferences will discuss about short stature, even precocious puberty in one odd case of hypothyroidism, thyroid hyperplasia, polycystic ovary, multicystic, everything. The full-blown presentations are well known. However, subclinical varieties, the child may be screened routinely, as I said, in some of these corporate setups on general check, or any weight gain, even mild weight gain, or when they undergo another checkup for cholesterol, general check, or some subtle alteration in growth, anemia, general weakness. You can see that every paper will quote everything, and ultimately a thyroid function is done, and marginal abnormalities are being referred to for specialist consultation. So the presentation can be vague, and one need to be very careful in giving importance to the TSH, and we will discuss in the next 5 minutes how the data says. I will not spoil your Saturday evening by asking you to squeeze your eyes to go through this, but just to tell you that these are all the number of papers. Many of them were less than 30-40 patients, only one or two having a lot of patients, where the natural history of subclinical hypothyroidism in children were studied by various authors. One was an Indian paper by Gopalakrishnan et al., which showed that out of the 32 children who had subclinical hypothyroidism, in that paper followed up over 2 years, that was one of the very good longitudinal studies, not a cross-sectional study, only 4 children progressed to overt hypothyroidism. By definition in these research papers, overt means when the free T4 goes lower than the lower limit of the lab, and TSH is well elevated. So it shows that most of the children over a period of 2 years actually do not progress. And that's what I mentioned, that if you get a thorough history and you know that there are no pointers to any permanence of hypothyroidism like those drugs or any other thyroidectomy and such issues, most of these children with a suspicion of autoimmunity, the remission and exacerbation and fluctuation of these antibodies will mean that many children need to be only followed up and not to be treated reflexly, is what the natural history suggests. And there are few papers where they have tried to treat children based on the levels. These are all a couple of papers mentioned in our review also. And you can see that very small group of patients in many studies, most of them showing no significant difference in the outcome for whatever reason, including neuropsychological assessment in one paper. Recently, there is a paper by our colleague from Chandigarh, where they showed that even in obesity, it has no role, etc. So in general, unless the TSH is progressively increasing and the T4 levels are progressively going down, or the child is showing clear signs, clinically documentable signs of hypothyroidism, you need to only monitor these patients and more often. So in this background, we did a study a couple of years back, and this was published in Indian Pediatrics, where this was the hypothesis that when the data is saying this, most of the children, and many were not South Indian papers, we with our pediatric colleagues from Apollo Hospital, Chennai, where I was working at that time, we did 40 children who had subclinical hypothyroidism screen, and we followed them up for next 1 year. And the main conclusion in that paper was only 3 children actually progressed to overt hypothyroidism out of those 40. And almost 21 of them returned back to normal, with 16 remaining in the same state. So which means, and when we see at the predictors of which are all the patients who are going back, as usual, the same thing, like female, the girls, elevated TPO antibody with a family history of thyroid dysfunction or goiter, those are the patients who need to be careful. All other patients can be reasonably followed up less frequently also. One caveat in this paper is we didn't do iodine, that was not available at the time with us. So again, showing that reassurance and clinical observation, masterly inactivity is most often the necessary thing in our patients. So in fact, we followed up children even up to the tune of 15 in this patient, in contrast to the usual cutoff given by many guidelines as 10. So in our paper, we suggested that maybe even up to 15 we can wait and monitor them once in 3 months or 4 months in the first year. Most of them did not progress. And after this paper in 2017, there are more than 2-3 papers who have done a similar observational studies, and again showing the same thing, that most of children only need follow. Last slide, I'm coming to my time. So, in summary, what I would like to suggest with the available information on subclinical hypothyroidism, because of accessibility and easy testing facilities in many centers, children undergo thyroid function testing with slightly abnormal values. More often, adult cutoffs are used. Age-specific cutoffs are unfortunately to be defined even in a better manner with the recently available third-generation assays. So the first step for a general pediatric colleague will be, please repeat the thyroid function test from the best lab possible in your regional place. And if it is still elevated, and if you see any clinical signs of these pointers which are favoring progression in the form of goiter, a girl child, TPO antibody being significantly elevated, or any other autoimmune history like alopecia areata or vitiligo, or any family history of goiter or thyroid dysfunction, they are the subset of patients whom you need to be more careful, monitor more closely. If the TSH is showing progressive increase, start with appropriate dose of thyroxine. Otherwise, the usual dictum in almost 2/3 of our children probably will be to clinical follow-up and reassurance, but you need to keep this child on follow-up. That's very important. Thank you very much for your kind attention, and I'll be happy to learn more from our senior pediatric endocrine colleagues who are listening to this talk. Thank you again for the opportunity.
Thank you, sir. That was a very excellent and lucid presentation, and thanks for sharing us your valuable experiences towards subclinical hypothyroidism. There are a couple of questions from the audience side. Dr. Rajni, ma'am, will you be?
Yeah, Divya? Hello, can you hear me? Yes.
Yes.
Thank you, sir, for that very interesting talk. There are a few questions in the chat box. One is that, is the term subclinical hypothyroidism used only in acquired hypothyroidism? Since we see a similar picture with normal free T4 and elevated TSH in the infancy period.
Yeah. I think by semantics and convention, we don't use the word in congenital hypothyroidism diagnosis. I think I may be corrected if there are any changes. I think other senior experts are here. To the best of my knowledge, we don't use this word usually in congenital hypothyroidism. We use transient elevation in TSH. If you are very purist in endocrinology, you can call it euthyroxinemic hyperthyroidropinemia. If you want a different name.
And Dr. Ashima is asking, any interval you would suggest to repeat thyroid function test in patients?
Sorry, madam, I didn't get.
Any interval you would suggest to repeat? After how much time would you like to repeat the thyroid function test?
Yeah, as I said, if the child belongs to those subgroup of children who have those pointers for progression, obviously once in 3 months will be a better thing in the first couple of years. But if the child is, a male child with no autoimmunity, a general check, obese child, I will be less frequent, maybe 6 months or even less frequent. And it obviously depends on their, the follow-up and how far, there are other logistic issues also here. But only the children with these predictable pointers, we will be more frequent. I think that would be a logical answer.
And would the term subclinical hypothyroidism be actually applicable in children? Dr. Ahila is asking, the purpose of treating adults with subclinical hypothyroidism is to reduce adverse cardiovascular events, which is not applicable in children.
Yeah, this is, as madam is pointing out, this is the traditional thought, but there are quite a few papers coming on subclinical hypothyroidism. If the word is, as I said, you can call it by some other name. Elevated TSH, the problem we are facing is, what is normal TSH? That's the problem. The normal TSH in a child is like a 70+ person, the normal TSH is much above the limits of the lab. So we are unfortunately not having an iodine replete, non-goitrous, non-autoimmune background, healthy children TSH data. If that is done across India in a big manner and we have a normal TSH, then I fully agree with madam that we can be very safe in reassuring our children. Otherwise, the elevated TSH has some meaning, follow up. That's why we said don't treat. But it has an impact, even if subclinical is the word. on insulin resistance, development of obesity, dyslipidemia, etc. in a child. Even though I fully agree that immediately it may not translate to a cardiovascular outcome, but if that starts as early peripubertally, it can have an impact. That's why we are treating many other subclinical things also in the early, childhood. I think I'll have more inputs. I may not be the only person who is an expert in this. There are others who can share their thoughts on this.
There are some studies which are linking subclinical hypothyroidism to non-alcoholic fatty liver disease. So whether this is an association, simply an association, or causative, I don't know exactly.
Like in many situations in medicine, the interventional trials are not showing the same robust outcome in the what we want than the association studies. That's the second issue. But we have a problem in the definition itself here. That's what I learned in a hard way by reviewing the literature in grade 3.
Okay, there's one more question. Would we treat mildly elevated TSH with normal T4, male child with goiter and negative TPO? And another.
He's testing. I think best will be, the safest answer will be to follow up this. If there is progressive increase in TSH and dropping T4, that's the better answer. Like growth velocity in a child, a single cross-sectional, measurement will always be an issue in our setup. The safest answer will be to please explain to them and follow up these children and repeat the assay in a good lab and follow the same lab. That will be a safer answer.
Thank you so much, Dr. Mahadevan. Divya, over to you.
Oh, there are comments from others. I think it should not appear like I'm only lecturing. Raghupati sir is there. I'm seeing our colleague sir, Dr. Ari from Harvard.
Professor Raghupati? Sir.
I fully agree. You reflected all my thoughts. And
thank you so much, sir. It's a blessing for me, sir. Thank you.
Thing to add, except that nobody should jump and treat an elevated or mildly elevated TSH, which is the practice we have all observed happening everywhere. So I keep saying, are we treating the pituitary or the thyroid? But nobody even looks at T4 or free T4, and they say TSH is the most sensitive test for assessing the thyroid function. I don't think we can accept that. And 6 or 7, anything above the normal range quoted in the lab report, even if it is in decimal, everybody gets worked up. And I don't know how the parents or the general public reacts to only TSH. They are not even thinking of T4 or free T4. So that's my only statement.